All right, so what's the procedure? You know, as the nurse, you are prepping for insertion. You're trained to put all these things together. You have to grab all the supplies. In our garage, we have a neuro cart. It has all the necessary supplies on it. So yeah, you could load it up with everything. What do you need, right? But there's a bin there as well that has a lot of good supplies as well. So you got to grab all the things, and it should have what you need. It should have the insertion kit. It should have the actual Ventrix system itself, right? We now have a non-disposable system, so it might change manufacturers, but basically it all is pretty much the same. Where you are going to, you know, the neurosurgeon is going to place the catheter for us, and we're going to do everything else, right? And we got to prime it sterilely. All right, so when you prime a line or a CVP, that's not sterile, right? You're not putting sterile gloves on. You're not putting masks on to prime that thing. Whereas this is done sterilely, right? So it's a whole procedure to make sure everything is absolutely sterile as you're doing it, right? And if you look at the saline flushes, if you have someone's been working today, you have a saline flush in your pocket, it says not sterile, right? So it's not sterile, and it might even have preservatives, right? And those preservatives eat away at brain tissue, so that's not good, right? So not only you learn not lose your childhood memories, you're going to learn how to function. Okay. So that's the idea behind the different prep that you need. You need clippers, right? You clip the skin. You never document that you shave the skin, because then they say, well, now you could get ingrown hairs and acne, and then that's going to ruin the surgical site, and you could get surgical site infections. You always say, I clipped the hair, never shaved, right? You got to prime it sterilely, right? So you need sterile saline. So where do I find sterile saline in the hospital? It's just a saline bag. Those are sterile, all right? The bags of saline, the 1 liter bag, 500 bag, 250 bag, those are sterile salines. The syringes are not. The pre-filled syringes are not sterile. So there are sterile ones that are pre-filled. You'll find like sometimes in central line kits, they'll be sterile. They look very, very different than a regular, clear plastic packaging, right? So then we got a transducer cable, because we're going to be able to transduce this, right? So it's going to go to the drain over there, but also we go to the monitor right here. So we have the monitor, that's transducers right over there is a transducer, and we're able to go to the monitor to be able to see our waveform, right? So that's the idea behind just like a regular hemodynamic setup, except you're not grabbing what? When you are setting this guy up, you're not grabbing a pressure bag. You notice there's no pressure bag here, right? Because we're not going to be putting fluid in the brain at 3 mLs an hour. They already have increased ICP. That doesn't make much sense, right? So also that's that's going to cause a lot of problems really quickly, even if they didn't have increased ICP. All right, so you don't grab a pressure bag. All right, so then we're going to clip the hair, and we're going to place a nice dressing when we're all done after they place the catheter for us, right? Number one step right there was the neurosurgeon to place the catheter, and just like an A line, you hand over the primed tubing for them to hook up, right? Same thing for us, right? So we are going to get all this fluid is going to drain, right? And it's going to drain right here, right there. So just follow it along there, right? And it's going to drain. They have it offed right now, which is, they're probably getting a measurement so that all the pressure goes right here for my pressure. So I'm getting an accurate, pure pressure of the patient's brain, versus if I turn it, if it's going both ways, right? Into the buretrol, if it's going both ways, I might be losing a little bit of pressure. So sometimes when we grab pressures, we have it just open to the transducer itself to get an accurate pressure. And of course, you have to zero the transducer. You have to level the transducer as well. You don't level at the heart, you level at the brain. And we'll talk about where and such. As far as the dressing is concerned, you want to make sure this dressing does not come undone on the sides, right? So how do you do that? You grab some tincture, right? Some tincture of benzoine. Our little tincture is going to make it really, really sticky and tacky, so that it will then, the tegaderm will stick to the skin. And what impedes that is hair. So you have to do what to the hair? Good, nobody said shave. Or you're going to clip the hair, right? You clip the hair, and then you're going to apply the tincture there. Of course, make sure the hair's gone, otherwise you're going to have little patterns, like little iron patterns, like from the science store. All right, so anyways, you want to make sure that you have a nice clean base, and then that's going to, of course, be prepped for the procedure. They're going to place the catheter, and if you have a good doc, they're going to be tunneling the catheter. That's the best way to place these. Okay, put our tegaderm over it, and we put a biopatch. If you talk to an older nurse, that's controversial, right? The little biopatch there. That's the brand name. The actual name is a chlorhexidine gluconate impregnated sponge. All right, so it's a sponge that's impregnated. So that is the best thing to do nowadays. They used to think back in the day that it was super toxic. The preservatives or the CHG itself was toxic to the brain tissue. But since 2010, we know that it's the best thing to do. Right, it's to put on every peripheral IV, not peripheral IV, but every central line, every dressing, etc. are great to use our chlorhexidine. Right. And then, of course, we'll talk about the orders, right? So you are leveling this with the brain right here, right? So if I put the brain higher in bed, I'm going to get a lot more drainage into my chamber there, right? So it's important that we lock the bed, for one, so no one does that accidentally. But also we want to make sure we let the doc know, like, how much do you want to drain, right? Do you want to drain over 10 centimeters, over 20 centimeters? Where do you want to be at, right? Because we do level it, but then we kind of raise it just a little bit, like 10 centimeters, 20 centimeters, whatever it may be. Okay. And then, of course, usually at the beginning, we're open to drain. And then once we're starting to trial the patient, once they're doing better, waking up, then we'll start, trialing them off the ventric. So we'll just clamp it, right? Have a little clamped right there. Now it's just them and their ICP. We're not doing any extra work for them. Okay. And then you're documenting every hour. You're looking at the CSF itself. It's coming out right there. See that CSF? That CSF is bloody, right? But you can't say it's bloody CSF because it sounds like you're saying a curse word in Britain, right? You have to say that it is what kind of CSF? It's sanguineous or serosanguineous or serous CSF, right? And you can say blood tinged, I guess, but it is also, you're looking at the clarity, right? Is it clear, or is it what else? Is it cloudy, right? So there's coca is the analogy, right? So the color, the odor, you're not going to be smelling the CSF every hour, so don't chart the O, right? So, but you are going to chart the clarity and the color, right? So the color is it bloody or is it straw, right? Or is it red or is it straw colored? Straw is normal, right? And then we also talk about the amount, how much is coming out. If 25 cc's is coming out, is that too much? Yes, right? We only produce about 20-25 mLs an hour, right? So we don't want to be taking all the CSF out every single time, every hour. And yeah, at the beginning of the first couple hours, you might pull a little bit extra, but when we're on maintenance mode, we're not going to be taking too much out, right? And of course, every hour, you're going to be looking at the ICP, CPP, and MAP, calculating those and making sure that it's not getting too low. And we can do a strip every 1 to 2 hours as well to make sure our waveforms look great, right? There should be 3 humps. They should be nice and stepwise. If there's anything but that, then that's a problem.
What is the ideal amount to drain every hour?
So no more than 20 is the right answer. Yeah. If it's 0, that's wrong. That's not good, right, unless you had it off to drain. And that's happened to the best of us, where we forgot to turn it back, open the drain afterwards.
Gotcha.
Okay. So the insertion, right, as we mentioned, it's placed through a burr hole in the brain, or they literally poke a screw all the way in, right? I don't think I've pictured there, but they're going to go all the way in, and they're going to then place the catheter, just like a fancy peripheral IV, and the needle goes in, and what comes out is the catheter is left behind, right? So the catheter is left behind here, and we're able to drain all this stuff, right? And we're also able to take a little bifurcation, right, and get some waveforms off of it as well. There's 2 options. We can tunnel it, or we just have a little antenna like this guy right here. There's a little antenna that we could leave the patient with. And that's not great because bacteria are great at traveling down this antenna right here. They can go all the way down. Whereas if they go in right here, they're not omniturners. Right? They can't go left all the time. Right? They don't have magnum. Right? They're not able to make that left turn at any point. So we did like 2 left turns. Like, oh shoot, right? So that really confuses bacteria. So they're not able to do that, and therefore it's much better for infectious purposes. Okay. So what else? So we're going to have same supplies we mentioned before. Get everything ready to go, and the doc's going to place it for us, and we're going to make sure we've primed the whole thing. In what fashion? And sterilely, right? This whole thing is done sterile. It's a whole to do, and you got to watch someone do it a couple times, and you can get practice to make sure your sterile technique is impeccable or immaculate. All right, so priming, again, no bubbles, right? Our brain cannot overcome the bubbles. These bubbles in the catheter might be the end, not for the brain, but the end for your waveform on the monitor for sure. So you got to make sure that there is no bubbles because it might not be able to overcome those bubbles, right? So we're going to then go ahead and make sure we're nice, clean, sterile flush all the way through this way, right? And also flush through our catheter as well. This system's a little bit wonky. Usually we put you can choose where to put this guy. We usually put it over here on the little port right there. And it's level with the brain at the same time. Okay, this does come separate, so we're able to attach it. So if you look at the ones that pass around, you can see the transducer there. We usually attach it to the side over here. Okay, so this actually our reusable one it has a little port for us on the side to place our transducer. Okay, so again, sterile saline, that's preservative free. Otherwise, the preservative is going to not preserve your brain. It's going to necrose it. So make sure we're not putting preservatives in the brain. Okay, a blunt needle so we can grab the saline out of the saline bag, right? So we don't got it. You're not gonna siphon it like an RV stop, right? And then sterile gloves, right? You got a mask in place. You got your dead end caps because remember these guys come with what? Fenestrated caps, right? So they have holes in it. So we don't want holes to be spots where our bacteria can be introduced, right? So to make sure that those are open for us. All right, so what else? We got to make sure that we're flushing all the way through, and there's no bubbles. And then we hand off the device right here, the tip, to the provider once they've placed the ventric, right? And then what else? So sometimes there are troubleshooting, and this is once you've had an ICP a couple of times, you're going to talk to your charge nurse, talk to someone who's done ICP a couple of times to troubleshoot. You got bubbles in the line. We have a few options, right? We can, if you need to flush it, you got to flush it, after the, or say, you got to make sure you're not flushing into the brain. You got to make sure that you're turning the stopcocks off the right way so that everything's flushing backwards, right? Just like if you're troubleshooting a regular IV for a patient, there's bubbles in your line, you're going to clamp the patient's IV, right? And you're going to aspirate, right? Or you're going to flush it, right? Whatever method is best, okay? It should only be done really by a senior RN or charge nurse once you get used to this, right? Because it has to be done sterilely. And you're not going to just grab a regular sterile flush or not a non-sterile flush from the med room. You have to have a saline bag and the whole setup again. Okay, and the reason for bubbles, why would you have bubbles in the first place? If they didn't secure it tightly right there, that could be a problem. If you didn't secure it tightly to the side over here, it could be your problem. Or sometimes there's a leakage in the brain right there, right? It's not a secure dressing. Okay, and air is getting underneath the dressing and make its way into the system. Okay, so that's the idea behind looking at is troubleshooting bubbles. And yes, when you put a ventric in, you don't always get nice clear CSF here, right? Sometimes you get nice bloody CSF. So bloody CSF can definitely clot the line just like it can clot the ventricles. So you might have to flush it at some point. Okay, zeroing and leveling. So zeroing, right? So zeroing is, does the patient have to be there? No, right? You hook it, you prime the whole thing, you zeroed it, and you call the nurse, hey, I'm ready for you. They, okay, I'll be there in 5 minutes, right? You can zero it without anybody there, right? And so you have to zero, you make sure it's plugged into the monitor, hit zero on the monitor once you are open to it, open to air. So this would then turn off that way, and it's able to then see air, right? So it's the same as A line, same as a CVP. Hit zero on the monitor, and that will then get you a zeroed hemodynamic line, right? It can be done prior to even attached to the patient, right? So when would you zero a line? Like I mentioned, the hemodynamics, really when you don't trust the nurse before you, that's really the only reason, right? Or it gets unplugged, right? So it gets unplugged, and then the nurse before you don't trust because I don't know if they know how to zero, right? So then that would be a reason to go ahead and get a new zero done. There used to be the myth that, or not a myth, but the older monitors, they used to have like this hemodynamic drift every 24 hours or 48 hours or so, but that's not true with the new monitors. All right, then leveling. So we do not level it where there are other hemodynamics. It's not leveled at the phlebostatic axis. That is a no. We're not leveling it there. Where you want to level it at the brain, right? You want to be able to get in the brain pressures. Otherwise, if you leveled it down at the phlebostatic axis, your pressures will be off by this many centimeters, right? And every inch is about 2 millimeters of mercury off, right? So we want to make sure that we are not off by like 7 centimeters, right? Or 7 inches, because that's 14 points of ICP. And who knows a normal ICP? Same as respiration, it's 12 to 20, right? So 12 to you're already at 14 if you're off, right? So we got to make sure that we have a good a good leveling. Yeah, we're gonna make sure we're leveled at the right spot. And where we're leveling it at, right, we're making CSF right there in the system right here. If we zoom in right there, it's called the foramen of Monroe, right? So this little foramen right there is what we are leveling it to. Okay, so we're leveling it right there. So if we like look on the outside, what's equivalent to that, what's lateral to that? It's the tragus of the ear. All right, so the tragus right here. This guy's a pro. He pierced his tragus, right? So that's exactly where, you know, he's helped the nurses. You can get this little device right here. You can loop it around his little piercing right there. It's like, thank you, sir, right? So no, I'm kidding. Yeah, that's not the reason why the guy got the piercing, right? So that's a way, that's the target for our leveling. You might have some older nurses who will level it like halfway between the ear and the outer canthus of the eye. That's way too cumbersome, right? So this is a very clear way to figure out where I should be leveled. Okay, so we're leveling this little the transducer, right? And sorry, the system, I should say. The transducer we level also with the system as well. The system should be there as well because here's our system, right? And our transducer are all level at the same spot. They're all looking at the patient. And what if the system was lower, right? Well, that would make sense. That would mean that I'm draining too much, right? If it was lower, that's everything that spills over is going to spill into that buretrol. So we got to make sure, usually when we hook this up for the first time, we're usually about 10 centimeters above. You know, anything that spills over 10 will spill over into this little bathtub here, right? So we level our transducer and our system at that foramen of Monroe or that tragus of the ear, and whatever spills over into that 10 centimeters above the foramen of Monroe will, you know, increase our, will improve our ICP, I should say. Okay, if the ICP is super high at 10 centimeters of water, well, shoot, I'm just going to lower this a little bit, and that's going to allow more ICP to drain, right? Just like with our hemodynamics. If I put the transducer down on the floor, it's more gravity onto the transducer. There's more gravity into the buretrol, right? If they're draining too much, I can raise the transducer. I can raise it up so I don't have too much drainage occurring, right? Or the ICP is, you know, like 4, and I got like 25 out last hour. I can you know, call the doctor and say, can we raise this up a little bit, right? So 10 is usually a starting point. Usually most of them start like at 20 centimeters. Okay, that's above the tragus. All right, does that make sense? That we level it and we level the transducer and we level the system at the tragus of the ear.
So right there, you have to take off the cap too when you're leveling it, right?
Leveling, you don't have to take the cap off, right? So the cap itself, right, these little caps that are on here, our transducer just needs to be able to see air when we are zeroing it. So zeroing and leveling are two different things, right? So when you're leveling, you've zeroed your transducer. The monitor knows that you're not in Venice Beach anymore. It knows you're at 678 millimeters of mercury in the high desert. So it knows you're up there, all right? So that it's not giving you a millimeters of mercury that's off by like 52 points. So that's why I won't put out a value for you. So leveling it, you're going to level it at the tragus of the ear. So that our system as well is leveled at the tragus of the ear. This is a little bit low actually, but that's also leveled. So everything's leveled at that piece, right? And if we have to, we can raise or lower it based on the ICP and based on how much drainage is coming out. Okay. So in the meantime, though, we're going to be getting our ICP readings every 1 hour. That way we know if we have to then adjust it or make some changes. Right, we are making sure we are draining CSF every hour. If nothing's coming out, that could be a problem, right? But I can troubleshoot it. I can lower a little bit. It's like, oh yeah, it's draining some. And I make a phone call and say, hey, I got no CSF out last hour. It's still draining. Do you want to go from like 15 to 10 centimeters of water? All right, so I'm going from 15 down to 10 centimeters. So 15 down to 10. Okay, so that would then maybe improve my CSF output. Hey, no, they might say, no, that's fine actually. Let's go ahead and do a clampy trial. Let's see if they can come off this thing in the first place, right? They might be getting better. Okay, or worst case scenario, you get no CSF output, and now that's because you have a clog in the drain, or you have air bubbles in the line. So that's our troubleshooting we're doing every hour to make sure that it's draining. Okay, make sure there's fluid in this buretrol right here. All right, there's fluid in the buretrol, and then at the end of the hour, we take all that fluid and we pop it into this little drainage bag that's underneath, and then that's a little stopcock that's engaged there, and you make sure the stopcock is put back up so that it measures for the next hour, right? So that's the idea behind these drainage bags. These drainage bags only get changed when they're full. All right, you don't change them like every hour. All right, so that's the idea behind the drainage. And of course, it happened to the best of us as well, where you forgot to turn it back off to the Buretrol. And for that 1 hour, it was just draining directly into the bag. All right, that's the whole purpose of the stopcock below the Buretrol here, is to get is to measure every hour. Okay. The other thing that can be done is it can get samples. You get a little sample out there, a little sample from the Buretrol piece. You get a little CSF sample. That's also things, right? So they got like 10 cc's out the last hour. You can get a little 10 cc's of output to measure to get a CSF sample, see if they have meningitis, see if they have any kind of weird, cocci developing, right? All right, so that's the idea behind the measurement every hour, measuring the ICP. We're also measuring how much CSF is coming out, right? So CSF sampling can be done. It can be done from any port passively, but usually we'll grab a little, 10 cc's or 15 cc's at the end of the hour. All right. The drainage bag we change when it's full. We don't change it otherwise. And the whole system does not get changed every 3 days or 4 days or 5 days or 7 days. It only gets changed as needed, right? If the whole thing's clogged off because they had a bleed, that might be a reason to change the system because it's literally clotted off. It's not able to do its thing. Okay. And of course, intraventricular administration we mentioned is an option, right? They can inject it. Yeah, they can do a little port there, like it's called, I think, a myoma or Myanmar or something. I forget what it's called. A little moya, I think it's what it's called. A little port they can place frequent injections, or with our ventricular device, it has a little catheter close to the brain that we can place our drainage into. So here we got a little catheter close to the brain. We can put a little syringe in there, and we can go ahead and draw you could draw samples, but it's really for the intraventricular administration of medications, right? If I was going to draw samples from that, I would not aspirate. I would let them just fill up passively over the hour. Okay, and then documentation. What are you documenting? You're documenting the orders. Make sure the level orders are correct, right? Make sure that it is either clamped or open the drain, just like any kind of other drain, right? And of course, you want to know when to call, right? Do I call you with an ICP greater than 15, greater than 20, greater than 25? What do you want, right? And they might even give you specific instructions. Say if your ICP is greater than 20, go ahead and drain 10 cc's. So all you're going to do is, bring the whole Buretrol down and get 10 cc's out and then put it back. Okay, and then nursing documentation. All right, so all the stuff we talked about above and our hourly stuff, hourly CSF and hourly ICP. So red flags and caveats, right? So any kind of time you have a change in mentation, you have no CSF, right? Or you have a change in CSF. It went from bloody to clear and back to bloody, that's a problem, right? If it started bloody, that's fine. But if it started clear and it went bloody, that's definitely not fine, right? So any kind of return to bloody is never good. Okay, you got greater than 20 mLs in output and it wasn't your fault, right? Then it's something we need to get adjusted, right? We need to raise the ICP so we're not draining so much out of the patient, because everything that is above a certain point is going to get drained, right? So if we raise the Buretrol a little bit, then less will get drained. Okay. So a drop in the output or no output, as we mentioned, is a problem. And then waveforms. The waveform we'll talk about, but the waveform's dampened, just like with A-lines, right? I mean, could something be what's in the way? Yeah, it could be positional, maybe, but not really in the brain, right? They're not like bending their scalp, right? That means they have what going on? They have a clot in the system, they have debris in the system, they have bubbles in the system that are getting in the way, making waveform go from nice 3 humps there to a dampened waveform, right? All right, so what else? So other caveats, you want to make sure your head of bed is always where it should be, right? 30 degrees, and that no one's playing with it, and no one's playing with the level of the bed as well, right? Everyone needs to be needs to let the RN know before they go in the room, right? So lab goes in there and they raise bed up all the way to the working height, right? 8 feet in the air, and that's going to do what? All that fluid is going to drain really quickly into that canister, right? So we want to make sure that we are in the room every single time. You just get a little sign say notify nurse before entering. Okay, and then what else? So transport. So again, you want to make sure that we are off to the patient, right? When we're transporting, when we're doing any procedures, bed baths, anything that you're not 30 degrees and leveled, you should be clamped. That way we're not, excess CSF's not being drained from the brain. Okay, we talked about sampling already. That is done passively, or you just grab a sample from the buretrol when you're sorry, over here, when you get after the first hour. Okay, medication administration, that's not us, and dressing changes, that is Q 7 days of PRN. And what do you dress it with? Biopatch is okay to give. You get Tegaderm, and you're going to do what to the hair? You're going to clip it, and you're going to put tincture of benzoin, and that's going to make it tacky so the Tegaderm sticks. That way air doesn't get in there, and also other things don't get in there as well, bacteria and such. Are your patients not lying perfectly still? They're crying, laughing, coughing. They may need sedation, or they may need something else to fix that, so we don't get excessive ventricular drainage. So we can just clamp it. Okay, so complications of an EVD. The most common is infection. You get a ventriculitis. You get an itis of the ventricles of the brain, and obviously that's not great. And that's basically means that we didn't wean it fast enough. So we should be having weaning protocols. So we're not keeping Ventrix in for 5 days, 10 days, 14 days. That's too long, right? We might do CSF cultures if we notice that it changes clarity, right? It went from clear to cloudy. That'd be a time to get a sample of CSF, right? Especially if they're getting fevers, they're more altered and other things, right? It can cause meningitis too, but usually it's a direct pathway right to the ventricles, and we get an inflammation of the ventricles, right? It can cause a hemorrhage, right? As they go in, it can cause hemorrhage, like initially. Usually not after a while. Won't do it. Usually after a while, it's infection. All right, the drain getting clogged is very common. They might need to, have the neurosurgeon flush into it or aspirate, but it's not our job to do that. But in the meantime, our job is to fix everything proximal, everything proximal to the patient. Okay, and of course you'll have a damper waveform at that point. If you've got excessive drainage, we'll make sure that that's not happening, right? Make sure it's not more than 20 mils an hour. Make sure that we don't accidentally remove it. That's happened where a patient pulls out their little antennas, right? When it's sutured in place with a tunnel device, that lends itself to not being pulled out, which is nice. Okay, and a CSF leak, right? So they have a clogged EVD. You might see drainage start coming up around this insertion site. That means definitely it's clogged because everything goes by the path of least resistance, right? And a catastrophic CSF leak. So if the CSF just falls into the buretrol, like 100 cc's, they can cause herniation quickly, right? You're going from high pressure to low pressure, right? Everything's following this massive negative pressure of fluid leaving, right? So everything's going to go from the high pressure of the brain to the low pressure outside where you pulled the fluid through, right? So that's not good. You want to make sure that we're always leveled, we're always clamped if we need to be, or this clamp to the patient, that we are not having any kind of excessive drainage. Okay, so infection is a high risk, right? A drain could get blocked, excessive drainage. Fluid electrolytes could get off a little bit. That's why we're tracking our sodiums if we need to, and making sure that do we need osmotherapy? Do they not? Those are things we can track in the meantime. All right, so the weaning process. So again, it's just kind of like a chest tube. Chest tube is to suction. Is our thing to suction? No, but it is to centimeters of water, right? It's not really suction, but basically when you get it off a chest tube, you'll start clamping it, right? Same thing here. You're going to have it clamped and see how they do. With a chest tube, they get short of breath. If they get short of breath, they might have a pneumothorax that's re-expanded or a fusion that's re-expanded, right? Same thing here. So they might have a buildup of CSF that we might need to then open it back up and say, we'll try again tomorrow, right? But if they pass the clamping trial, then the next step is to get a CT scan, right? Get a CT scan to see that it is that we're not having ventriculomegaly. That means the ventricles that are not megalic or not a big ventricles, right? Make sure the ventricles have not increased in size. And if they did, and they fail the clamping trial like 2 times, 3 times, they might need to get their antenna switched to a VP shunt, right? A VPS, right? That's where they take the catheter that's in the ventricle and they reroute it underneath the skin through the neck. They might stop in the thorax or they'll stop in the abdomen, and that's called a ventricular peritoneal shunt, right? So they will then need to have that placed, and of course it will take the EVD out afterwards. Okay, so that's how we get people off EVDs. Either they're successful or they need to have that chest tube in permanently. They have like a Pleurex catheter for like a cancer patient, for instance, or a Heimlich valve until things get settled down. All right, so real quickly on waveforms, right? So there's 3 humps, and it should be stepwise, right? So that should be what it should appear to you. It's a stepwise decrease in amplitude. It starts off nice and strong, and then it goes down P2, P3. Pressure 1, pressure 2, pressure 3. Okay? So we'll talk about the different, why they happen. But basically, with that increase in ICP, as volume goes up, as blood goes up, as edema, edema goes up as well, that's going to have an exponential increase in the pressure in the brain, right? And as that happens, our compliance goes down. You'll notice P2 is greater than the other ones, and that is always bad. You should never have a P2 that is high. Everything should be going downwards, okay? So we have this ventric in place, so we can measure those. Yes, we have subarachnoid bolts that can measure it, but they don't pull off CSF, because CSF might be one of the things we can do to fix this rising ICP. So the normal ICP waveform, right? So normal ICP waveform looks like that, P1, P2, P3, and then my arterial waveform is a reflection, is being reflected into the brain, right? So normal ICP down here as well. Let's click this guy, right? So I got P1, P2, and then P3, right? So what's going on is I have an arterial waveform right here. That's my systolic upstroke, right? Systole happens, and it's going to, go bam, and it's going to hit that catheter right there, right? So that should be the strongest upstroke. That should be the strongest pressure waveform, right? And then what happens next is that, yes, it hits the catheter, but then it's going to go through the brain tissue and then bounce all the way back onto that catheter again. So it's literally, your brain is like a trampoline, right? If my brain is nice and compliant, it's able to accommodate that pressure, right? It's able to accommodate it like like a trampoline, and it's able to, it's going to bounce very high if my trampoline is very, very loose. No, right? And that's what I want. I want a loose trampoline for a brain, right? So I'm going to have a very, very high compliant brain. It takes that pressure waveform from the systolic upstroke and it just absorbs it, right? Whereas if I have increasing pressure in the brain, I'm going to crank this up, crank up my trampoline. All the springs are brand new now, and now the compliance is less, right? It's less able to comply. It's not concrete, otherwise I have broken ankles. That's not a fun trampoline, right? So just before concrete, we're going to make it nice and decrease compliance. We're going to make it super taut. We're going to make the ICP super high, and that's going to make it so that when it goes through here, it's going to bounce right back very, very quickly. It's less compliant. And that's where my P2 will start being higher than P1 even, right? So you can see that. So normally P1, P2, P3 should be stepwise. And P3 is a reflected SVR, right? As it hits our vasculature, it bounces back and we get a dicrotic notch. And that dicrotic notch is going to be translated into the brain as well. There's a little P3 over there as well, right? So those are my 3 humps, and they come from the arterial waveform, and now we're just inserting a P2 basically between each one of these, right? That's kind of the idea. So P1 is the arterial percussion wave, and then P3 is my dicrotic percussion wave, you could say, right? And you could say aortic valve closure, but we disproved that, and hemodynamics is really reflected SVR, right? But anyways, P2 is our tidal wave. As the tide goes through the whole brain and bounces back, did it go through super quick? That means my brain was less compliant and has a high ICP. If it went through and took a long time to come back and the pressure actually dissipated, that means my brain was able to comply with it. It was able to dissipate and accommodate that pressure. Okay, and you can see as the pressure gets higher and higher, what happens? Which one gets higher? P2 gets greater than P1. So the P2 starts getting higher. All right, so abnormal ICPs. My ICP gets high. I just got a high ICP overall. That's an ICP greater than 20. Technical literature says 22, but stop making it difficult. 12 to 20 is normal respirations. 12 to 20 is normal ICP. That's easy to remember. So more than 20, you're concerned, right? Then you might have a neurosurgeon say, oh, it's not greater than 22, it's still 21. But yeah, it's still something you can be concerned about the trends, right? So it's trending more than 20, and especially if it's sustained, like 20, 30, 40, and it stays up there at 50, right, for good like 10 minutes, 20 minutes even, 30 minutes, that's definitely a bad situation, right? So basically all the waveforms are getting really, really high. They may be able to allow compliance, they may be able to comply with this increasing pressure. And the point at which they can't comply, right, they're able to tolerate. What point they can't comply is when that P2 gets greater than P1, right? That's where they have decreased compliance to the brain tissue. So I have an abnormal ICP here. So you can see on the left, got, I think that was normal here, and I got abnormal over there. What else we got here? Sorry. All right, so we have a abnormal P2. P2 is not it's not dissipating within the brain tissue. It's going through and it bounces right back to my my catheter, and it's even higher than the P1. Okay, so that is a lack of compliance, right? So increasing pressure is less elastic, is less able to comply, and therefore we need to fix the brain compliance. So how do you fix that? How do you make the brain comply? You have to make it less, wind it down. You got to get rid of the fluid that's inside, right? So we can get rid of the fluid is one thing, right? Edema. If there's an increasing bleed in there, we got to fix. We can maybe take that out with neurosurgery. Okay, and and also we got CSF. We have a catheter here that we can pull out CSF. So one of the three things, CSF, volume, or edema, are things we can fix in the meantime. Right. Last thing is abnormal is when we have a P1 height that is reduced just because I have a low pressure. I have a low systolic blood pressure. My blood pressure is 85. That's not going to create a great blood pressure, right? A P1 is going to definitely be pretty low, right? So that's another abnormal that can occur is when my P1 is low. Is P1 less than P2? In that case, it can happen. But we're going to look at the other things that are happening before us. Like, oh, we already did all these things, and they might not. I don't think it's a compliance issue. It's just my blood pressure issue. Your blood pressure is bad. Okay, so those are our different changes in our waveform. We have a normal waveform A, right? It goes 1, 2, 3, and you got a P2 that's starting getting really high, and that could be a low systolic blood pressure. So I eyeball my systolic blood pressure looks great. Then now it's potentially a problem where I have decreased compliance, right? And then it can start getting just super, super high, which we have these different kind of waves, A waves and B waves. All right, so these are abnormal trends in my blood pressure over time. So you can see this 5 minutes, 10 minutes. So we got these A waves for about 5 to 20 minutes of prolonged high ICPs, right? Greater than 50 even. That's not good. That's going to be a lot of increased pressure in the brain, put a lot of stress, a lot of pressure, and even herniation on multiple structures. So that is if it hasn't herniated already, it's going to be impending herniation. So we're going to do everything we can. And the trick is where you're going to go to the crash cart and grab what? Hypertonic. Some hypertonic saline, right? Which is in the form of baby puke yellow, right? Baby diarrhea yellow is our bicarb, right? 2-acid bicarb is definitely what's going to be the next probably thing being ordered at this point, right? And we have B waves. So B waves are not as bad as A waves. B waves can turn into A waves though, right? They can go this way. So they are a warning sign. They happen for about 5 minutes, 2 minutes on average, right? 30 seconds even. The ICP just jumps up 20 points above baseline, right? So it keeps going all the way high, and then it goes right before it, right down to where it was beforehand. They precede A waves, and they are a warning sign that we need to figure out that something might be up. And they might be, maybe you forgot to clamp the ICP, or maybe they have a clog in the system, right? There's something that's causing this all of a sudden rise in ICP that's sustained, right? The other option is C waves, which are innocuous. C waves are not a problem. That's just where your ICP is high, but it's very, it's with respiratory variation. Is it high? Yeah. Is there something we have to do about it? Yeah. But it doesn't cause it's not impending herniation like our A waves are. Okay, and we're doing the same thing we did before. We're improving venous outflow, right? Making sure the jugular veins are draining good. Make sure there's not increasing hydrocephalus inside. We get a CT scan. If anytime there's deterioration in your patient, you get a CT scan to see if our ventricle's bigger. Is there a new bleed? Is there mass effect happening? Is there herniation happening? Right? So these are things that we would, we have a low threshold for getting CTs in patients, especially who have ventrix in place, right? Because we're alert to complications. All of a sudden we have no output and they have a change of mentation. Well, shoot, it could mean that the ICP is getting higher and higher inside the brain. Okay, so that's the idea behind ICPs.